Okay. Hey, welcome. Today is Friday, August 27th. I'm Tracy Lawrence for the Good Kids Club. And today I am talking with my good friend, Rose Rohloff, and we are going to be chatting about things that make you go, when you consider your health. And we chose this topic because these days, healthcare, healthcare is always challenging here in the United States. Part of the problem has been for years that healthcare is a business. And when healthcare is a business, that it runs at odds with people's needs for receiving care. And in the last year or so, some other issues have cropped up around healthcare that require us to be ever more vigilant, and that require us to ask a lot more questions. Because as Rose likes to say, you don't know what you don't know.
Yes.
So today we're gonna kind of volley this around a little bit, so that to give you some ideas of the kinds of things you need to be mindful of, and hopefully you know about these things before you or a loved one gets sick, because the last place that you want to be when you have these thoughts is in an emergency room or in a hospital trying to figure out what to do next.
So it's interesting. I shared
I'm
this.
sorry, just give me a second here, Rose, because
Sure.
Diane Carbo is joining us, which is awesome. Hey, Diane,
Hi,
how are you today? Oh, she flashed in, she flashed out. Oh no, I think she'll be back though. Just so you know, Diane is a nurse also, and she has a website called Caregiver Relief, and she's back. Yay. Okay, you're back. Yay. Hi, Diane. Meet my friend Rose.
Hi, Rose.
Hi, Diane. Oh my gosh, caregiver respite is such a wonderful focus.
Yes, it is. And I love the topic today of taking care of yourself.
And we're going to talk about things people need to ask, because a lot of people
love it.
Yeah, thank you. Now, Diane, you're in North Carolina?
South Carolina. I'm in Myrtle Beach.
Okay. And Rose is coming to us from Florida.
Nope, I'm in Michigan.
Oh, okay. It's so hard to follow people around. But you were in Florida recently. That's okay.
Correct.
Yes.
But well, it's interesting. I was going to tell you, I shared with another career veteran vascular nurse who's retired the topic today. And her comment was, the things that make you go, what? And, it's interesting. I think a segue from last topic of who do you trust to today is one, what is competency? I guess is, when you say, who do I trust and what should I question? Because it's interesting when I talk with these elderly people, some of the comments I get are, oh, they took such good care of me. They were so nice. And I think there is a huge blurred line between they were nice to you, but they weren't being competent and they weren't giving you good care. They just happened to be doing it with a smile.
Yes, I often say that, when we're in a crisis situation, we are often greeted by someone in a lab coat carrying a clipboard. And because of the way they are outfitted, we immediately assume that they are there to serve our best interest. And that's a recipe for disaster.
Right.
You
And
want to know who you're talking to and who they're serving, right? Who they're working for.
I
Well,
just
and the
had this
other question is
conversation-
what's the definition of quality? I think that is people don't know what they don't know.
Mhm.
And an example is I ran into this lovely woman this past week. She had a hairline fracture, closed wound. And it's like, oh, well, they're letting you take your boot off after 4 weeks. And she says, oh, well, I had to go back in. And I said, oh, why? And she goes, well, I got cellulitis because they said they bound my foot too tight. And I went, what? You don't get cellulitis from a tight binding. And then she just kind of haphazardly said, oh, they said MRSA.
Oh,
And
dear.
again, she had no idea what that meant.
Yeah.
And it's like they gave you Staph aureus that's resistant to an antibiotic. And it was a closed wound. And you don't get a staph infection because they bind your wound too tight. And what were they binding with a closed wound for a hairline fracture that's closed? So I just wanted to relay that story in to your topic of this really made me go, like, what is this story you're being told? And she never questioned it.
I see that a lot. In fact, I just recently had this conversation with another caregiver because one of the things I have an issue with, and a lot of caregivers have, is, in fact, this caregiver wanted to fire one of her hired caregivers in the home, and her mother wouldn't let her because she felt that even though the caregiver wasn't up to the daughter's standards, it was enough for the mother. And she didn't question the quality.
Correct.
And the competency. And I think that's an issue that many families have when they're dealing with caregiving, not just in privately, the professional caregiver in the home that comes into the home, but as well as every interaction they have with other healthcare professionals. And I think that one of the issues that we have is we as healthcare professionals let people down because we don't explain. And we put so much pressure on the families to do things that they're uneducated and unprepared to do.
Well, I equate it to, I don't know how to fix my car. I don't want to learn to be a mechanic. I didn't go to school to become a mechanic.
Yep.
But I still go out and ask mechanics and go, does this guy know what he's talking about? Is he trying to milk me for money? And that's the example I would give in healthcare is, are we going out and seeking veteran people to really question? Because what I've found is in having a conversation with a newer trained nurse, we talked about compartmentalization. And I said, you know, as older nurse clinicians, we were trained, you have to compartmentalize. You're there to do a job to make sure that you get your patient stable. You're on top of their labs. You're on top of their meds. You're on top of their discharge planning. You're on top of coordinating with the doctors. You're working and you're busy staying on top of that. And it's being compassionate and being competent. And she goes, no, if you're compartmentalizing like that, you're not, I want to sympathize with the person in the bed. And I said, but if you're sitting there and you're sympathizing with the patient, you're not caring for them. You're taking away from your job to get them stabilized, get them educated and on great care planning so they can go home with their family and friends. There's a disconnect, I think, in the mentality of, as long as I'm being friendly and I've got a smile and I'm being nice, it's not equating to competent caring
Yeah.
sometimes. Is that a good way to phrase it?
I like that. I like that. I tell my clients that they have to think of it as you're employing that doctor or that person in whoever you're working with at the time. You're employing them and paying them. You're their employer. You're paying them for their knowledge and their information. And if you just sit there and take what they say without asking questions, you're not getting the benefit of all their knowledge.
Oh, I love that. That's beautifully put.
So I think that, if you think of it as, hey, I want to get the biggest bang for my buck, because with the seniors, it's always about, their money and they're worried about the time. I'm thinking, I tell them your time is valuable, your time's important, and your money is important. So get the biggest bang for your buck, write down those questions, and don't hesitate to ask them. And don't be afraid to say, I don't understand.
Right. I work with a wonderful, wonderful neurosurgeon, Dr. Randall Porter, out of Barrows in Arizona. And I'm going to paraphrase him. He said, if you ask what the definition of a caregiver is, whether it be a doctor or a nurse, it's we are being entrusted with the privilege of caring for the life of a person, or more so, the person they care the most about.
That's lovely.
And I think that's been lost, is you don't understand. You're being entrusted with the greatest privilege of what's most important to someone. And I don't want to misquote, but was it Einstein who said, if you can't break it down and explain it as if you were speaking to a sixth grader, you don't know it? Again, I don't want to misquote, but I think that was
enough.
Yeah. If not, I just wrongly attributed it to him. But again, yeah, if a clinician can't break it down to that level to truly make anyone understand what they're doing, what am I treating you for? What am I ruling out? This is why I'm doing what we're doing. This is why we're giving you these meds. And no good clinician should ever question someone questioning them. It would be like, great, I want you to understand.
You know what? I'm gonna share a personal experience that I had this fall. I was up in New Hampshire. I had fallen, and it was due to I was on gabapentin, so it made me unsteady, and I'd fallen. So, and
for the viewers, what is that?
Yes, you're right. Your gabapentin is. It was for chronic pain. I have chronic pain. It is an anti-seizure medication, but they do give it for pain. And for me, it's a god-awful, terrible medication. It's very, I respond to very low doses. I'm very sensitive. It made me terribly off balance to the point where I couldn't walk. I would fall down. And that was on 300 milligrams. I had to go down to 100. Anyway, long story short, I end up in the ER. And I had hurt my elbows. So I go in and I tell them, this is what I have. I went in for the elbows, and I said, and I was also having stomach issues at the time. And so they were looking at it. They totally ignored my elbows, which needed to be dressed. I mean, they were stage 3 and 4 from the kind of rubs I had. That means they were thick and broken open and deep on my elbows. And they totally ignored those. And they just treated my stomach, and which I thought was very, very strange. So I questioned they get ready to discharge me, and they say, okay, you're ready to go home. I go, wait a minute here. I said, because it's during COVID, it was during COVID. So I said, I said, I need my wounds dressed, or at least addressed. And I said, if you don't have time to do it here, where's my referral for home care? And the nurse said to me, we don't do that. I went, what do you mean you don't do that? Yes, you do. I said, girl, what's wrong with you? Yes, you do. And she says, no, we don't give referrals to home care. And of course, for the VNA of Greater Philly doing marketing and sales, and I always went into the ERs and wrote up referrals for home care when they needed it.
Right.
And I said, I want that. And she says, and then I said to her, you need to go check. And she says to me, I have never been so insulted. She personalized what I was saying to her is that because she was upset that I said, you know, you don't know what you don't know. And I
Right.
need to have this. I said, are you new? And she says, no. She said, but we don't give referrals. And so it had to go to, and this is me. I'm an advocate for myself as well as others. So I asked for a patient advocate. A patient care advocate had to come down to the room and address the situation. And it was a whole hullabaloo because they ignored my wounds. They ignored a lot of things. And I thought, what is going on here? But in fact, they do not refer to home care. The emergency
It's
room,
an overarching problem, I think, from multiple facets.
yes.
But one of the things I've investigated is I've done side-by-side comparisons of training programs from the 80s to today.
Mhm.
And unfortunately, what's happened is they've cut out so many of the credits of the science and clinical training credits that have just been removed.
Yeah. Wow.
So it really starts from the education system.
Well,
And I equate it to when we were trained, we had to learn movement memory in school. So
correct.
we knew when we were sterile, when we were clean, when
Yes.
we were dirty. So while we were functioning in a fast paced, it's like this glove just got cross-contaminated. So I'm only going to use this glove and I'm going to move things with my elbow. And I need to go change this glove out, or I need to go rewash my hands.
Yes.
And that's missing because I've read studies going back to what you just relayed, that these nurses were offended and indignant when the patient said, please go wash your hands.
Yes.
And
Yes.
the nurse's feelings got hurt. And I'm like, you're not supposed to have feelings. You're
That's
there
what I
doing
told
a
her.
job to make sure you don't give an infection to a patient. And,
Yes.
and we're laughing in it, but it's very sad that that is
It
the
is.
case.
It is. A couple of years ago, my husband was sick and he was on IV antibiotics. He had a central line and I was his infusion nurse. What
Yep.
fun. And he developed a secondary infection. So my husband's infectious disease doctor sent us back to the hospital. And we get to the hospital and we're waiting in the room and the nurse comes in and she's ready to take blood from him. And he said, I have a central line. You can take the blood from there. And so she grabs the central line and she's about to take blood from him. And I'm like, whoa, where's the alcohol?
She never
And she's
cleaned the
like,
port.
Yeah.
yeah, she's going like right for the port. And I'm like, and you know, okay. And she went and she got a box of alcohol, you know, packets. And my husband looked at me and he's like, thank you. It just, I mean, how basic does it get? You
Right.
don't swab with alcohol before taking blood from somebody?
And 2 points to that to tag onto you is exactly right. Going back to things that really make you go, I
Yeah.
can't tell you how many times I've seen nurses, phlebotomists, whatever, they don't clean the skin properly, or they might swipe the skin with just alcohol, but then they take their non-sterile gloves and they're putting their fingers with the non-sterile glove, which is not clean. Well, it's technically considered clean, but
Yeah.
it's not sterile.
Yeah.
And they're contaminating the area before they're going to inject the needle directly into the vein.
Yep.
And it's amazing to me how many people are just, oh, well, I got phlebitis when I got surgery. And it's like, you're not supposed to get phlebitis. It's not standard. It's not normal. You shouldn't be getting infections when you have surgery.
One of the things that I do when I've had people that have had surgery is I stand there, and if you want to see a doctor sweat and cause anxiety, ask him what his infection rate is.
Oh,
And
yes.
they're so insulted that you would even think
To ask that
to
question.
ask that question.
Because your
And
patients aren't supposed to get surgery with closed, clean wounds.
yes, yes. But I do, before surgery, I ask, what are your infection rates? And that's something that is a no-no, according to the doctors. That's a personal affront to them. And I don't care. I
Correct.
want to know. I don't care what your background is. This is, for me, I need to know for my own personal satisfaction. And I think that that's one of the things that we are lacking in our society today is, number one, we have, I'm going to say we have untrained people because, and this is my personal opinion, forgive me, because I have a son that's a CRNA, so I mean a nurse anesthetist, so he's had good training, but academia has ruined nursing because they've taken the book learning part of it and made that more important than the practical, clinical, hands-on experience. And they don't give them enough of the clinical hands-on experience until they get their master's and they specialize. So that nurses
With the reduced credits in addition to pulling them out.
correct. Yes, yes.
Like they're
Well,
not
I
even
mean-
getting the hardcore sciences at the same level, because I asked a nursing student one time, she said, well, I'm studying ABGs and I'm having a hard time with it. And I said, well, go back to your basic acid-base balance equation
Yes,
and critically think it through. She goes, I don't know what that is.
I know. Oh,
They
yes.
never learned it.
Yeah.
They're not understanding the chemistry of when they're injecting drugs. What is it chemically doing in the body? How is it interacting?
Okay,
Yeah.
so I got to ask a question because you guys are nurses and you know what you're talking about. How do average people who are not nurses, who don't know necessarily that in order to prevent infection, the professionals treating you should be doing A, B, C, and D? What should they be looking for? What kinds of questions should lay people?
Well, I'm glad you brought that up, because with Delphine HC Innovations, my company, under that, I do what's called HC Aware, is to give these presentations, because this isn't something we can just tell you in 5 minutes.
Sure.
That
sure.
I give these presentations to first and foremost say, okay, guys, you don't know what you don't know. You need to question. What questions should I ask? And what are things I really need to look out for? And especially with avoidance of cross-contamination. So that's a lot of what I do with HC Aware, is their education presentations all around this. And somebody else brought up a point to me. They're like, Rose, what's with all of these, acronyms? We don't know what these 3 letters mean. And she's right. And it's walking people through, what are all of these acronyms that they keep throwing out at us?
Mhm.
And again, it's something else like HAI. We used to call it nosocomial infections, which
Mhm.
were infections that were given to you from a healthcare professional in the hospital or the doctor's office, wherever. But now they call them HAIs, which are hospital acquired or healthcare acquired infections.
Oh my God.
These are infections you're not supposed to get because you're
Like
getting
MRSA.
them through treatment.
Like MRSA and C. diff.
Yes.
Those are the 2 basic ones. There's so many more after that, or so much more worse. But anyway, from my perspective, having worked with caregivers on a very one-to-one level, basic level, I think that I love your ability to do courses, but we have so many caregivers out there that are uneducated in healthcare,
Correct.
educated in even good hand washing techniques, and they don't have the vocabulary knowledge to even know where to go. So I start with basic things like, you have to ask to tell them, ask basic, simple questions. I actually have 2 questionnaires that I give people when they get a diagnosis. I give them these questionnaires that ask these questions, especially if it's a brand new diagnosis, so that they can have a follow through. And then I tell them, get those questions and tape the conversation. Or write
Yes.
things down,
Yes. Thank you.
because I think it's really important. Doctors talk fast, nurses talk fast. I mean, Lord have mercy, they only give you a 10 or 15-minute period to spend with you before they're on to the next patient.
Yes.
And guys, if you don't know, I'm sorry, Diane, if you don't know, everybody's got the capacity to record with their phones. Don't be afraid to use it.
Yes.
I'm going to do another plug here too, is Dr. Porter, who I mentioned, created a company called Medical Memory. And there is an app you can do on your phone, and it records to a HIPAA compliant server.
Ooh.
Because they do studies, and I don't know the percentage, but they say that, people sitting in front of a doctor only retain about 20% of
I think
what's
that's
being
more
said
than
to them.
that's giving them way too much credit.
So I'm going to do a plug here for Dr. Porter. He created Medical Memory for that very, very reason. And he says, as a doctor, I record every encounter and send it to my patients because
That's
he
brilliant.
wants them to have informed consent. He
That's
wants them to
great.
understand.
And also, folks, it's important if you have a loved one who's older, or if it's you, everyone should be able to go to a doctor and have someone with them.
Yeah.
Everyone needs an advocate. All right. And if a doctor is reputable and cares, they should not have a problem having your advocate with you in the room while they're discussing your condition and treatment options.
And that's why I've kind of switched it to a health champion. And the only reason for that is because when you search for advocacy, it's now been really kind of cornered into, okay, we're going to get you access to doctors and around your payment benefits. And this is truly having a champion. This is your knight in armor next to you to do battle for you, because you're in pain, you're in stress, you don't feel good.
Mm-hmm.
Yes. So you need that champion with you.
Right. And somebody who's able to operate the phone and record the conversation. So you have that. Yeah, you have that backup, or someone who takes really good notes.
Yes.
And who isn't afraid to challenge the medical professionals you're talking to.
Yes.
Who's willing to say, wait a minute, I didn't get that right now. Can you repeat that? What exactly is that? We can't be shy.
Right.
About challenging these people.
And especially elderly people are afraid to speak up because they're intimidated.
Right. They don't think they're allowed.
Right.
It's you're breaking some kind of social contract. And to your point, very often, medical professionals are offended if you question their infection rate, right? Or whatever it is, you have the right as a person to protect yourself, your loved ones, your own body, what goes into your own body. You have the right.
That's the equivalent of going to a lawyer and saying, okay, how many cases have you won or lost?
Exactly. Yeah.
Yeah. There's nothing wrong with asking those questions. You're not doing anything. It's actually smart. And if someone is really good at what they do, they should be proud to share that information with you.
Right. And I could be a gastroenterologist and say, or gastrosurgeon and say, you know what? I come in with burst appendix or ruptured colons, which are dirty wounds. So my infection rate is based on that. But other than that, when I have elective closed, clean wounds, I get no infection rate.
Correct.
That would be a doctor where it's like, wow, you just explained it to me. Yeah, I get it. If their appendix ruptures, then
Exactly.
it's dirty in there because it's, spilt.
Release of intestinal bacteria.
Because I talked to a mother whose son went in for a shoulder surgery, closed wound. It was a repair of rotator cuff or something. I don't know which. She goes, he ended up in ICU. I go, let me guess, they gave him an infection. That's a closed wound. And he was a diabetic.
Oh,
So this is a closed wound where if you're following sterile protocols, he should have never gotten an infection. And especially being a diabetic, it threw him in the ICU.
Yeah. Yep. There's a great book by a doctor named Atul Gawande. It's really short. It's called The Checklist Manifesto. And I love this man because he also has another book called Being Mortal. But the Checklist Manifesto is brilliant because what it does is it basically says that professionals who do repetitive tasks sometimes forget to do the important steps. But if you use a checklist where you know, oh, okay, wash hands thoroughly, now put on gloves, now do this, now do that, then if they're using the checklist with every patient, they're not going to forget.
And that's what we're supposed to be doing.
Yes. And
those checklists are in place.
Yeah. In hospitals where they're actually literally using those checklists, the infection rates plummet because if you're doing the tasks in the right order for every patient, well, hey, you know, they're not going to get infections.
Well, let me give you an example of an HC aware that I educate people on, to your point, is it's the movement memory. I always plopped off my stethoscope, wiped down my stethoscope, and then washed my hands, and then went and touched the patient. How many people do not wash down their stethoscopes going from patient to patient?
that's why surgeons stopped wearing ties.
Yes, yes, because ties were a great infector. Yes,
Yes.
absolutely.
Yes, yes.
So Tracey, all of those are there. They're not being followed anymore.
Right?
One of the issues that I just came across this yesterday. I had a wife of a patient call me and they went to the doctors together. He's actively drinking, not well. They're early retirement because they had an early buyout. So they want to enjoy life. His active drinking has gotten out of hand. He's gained like 50 pounds. He's not well. COVID just destroyed his health. Long story short, they just came back from a cruise in Alaska, and she did not know how bad he was. But on this cruise, he had to take some Lasix. They ended up actually in Seattle where the weather was so hot he couldn't get out, and he lost like 20 pounds overnight. And she said to me, now he's in his late 50s, early 60s. So she made a doctor's appointment and they went yesterday, and he would not let her go into the doctor's waiting room she went into the waiting room, but did not allow her to go into the doctor's office with him when he was being seen. And she says, what do I do? And I said, well, first of all, he's actively drinking. He's denying everything. And he's probably, and I see this so much, they're lying to the doctor, and then he's going to come back and lie to you. And I said, did he sign a HIPAA form allowing you to have release of information to you? And she says, I don't know. And I said, well, that should have been done right there with this initial visit. And she says, well, I don't know. And I said, well, then you need to find out, call that doctor's office and find out, because there has to be some kind of good communication there, and there has to be some kind of knowledge there. But I find this all the time. And one of the things that I find very frustrating for me as a family member, not just as a professional, is I've taken in patients. Like I had a personal friend, an older woman, had a TIA while we were driving. She was driving her truck and I was with her. And I made her pull over. I took her to the hospital right away. she's a diabetic, had these before, but they always resolved before she got to the ER, the ambulance came. Long story short, she's sitting there and she's telling the doctor that she's compliant with everything, that she takes her blood sugars, she takes her insulin, she does all this stuff. Absolutely none of it was true.
Well, my question to you though is how is it a HIPAA violation if I'm giving information? I'm not asking for information, I'm providing information.
Well, here's the thing. The doctor, when I said to him, for me, because at that moment, I said, excuse me, nothing she's saying is true. She's totally non-compliant. He put his hand up and said to me, I don't care what you have to say. I need to listen to her.
Wow.
And I've had that happen to me several times. And they don't want, and I said to him, but you're totally getting the wrong picture. So doctors, and I know the caregivers must have that happen, saying, well, that's not true, that's not true. And they're totally dismissed by the healthcare person, whether it's the ER doc or a doctor in the hospital. Now with this situation with her, I said, I said to her, that's what I said to her. I said, she may not be able to give you information because he didn't sign a form for release, but you can certainly call her or email her with your questions and your concerns and your observations.
Correct. That's part of the detailed assessment that's missing.
Yes.
Because the clinical assessment would be backed up by the additional information you're providing. And again, you're not violating HIPAA by providing him information. You're not asking him for information.
Right, but she wanted to know what was going on with him. I told her, I said, I think there's some serious health issues going on, and they put him on, have they checked his liver enzymes? I gave her questions to ask before they went.
Right.
And of course, he didn't ask any of them, and she wanted to ask the doctor, and she wasn't going to be able to get that information. But I did say to her, I said, this is a new doc, and I said, you need to absolutely share the information that you have now with that doctor.
Right. And for people who are in that situation, I recommend that you try to have a conversation with the doctor on your loved one's behalf, one-to-one, without the presence of the patient. Just so you can let them have your perspective.
Yeah.
Because if you're going to try and do that in front of the patient, they're going to block you.
Right.
And what the patient says about themselves, is always the primary source of information, which is as it should be. But that being said, when you know things about the patient that they are not going to share because they have an addiction problem, because they have some kind of abuse problem, then it's important for you to have one-on-one conversations with the medical care provider outside of their attention span, because that's the only way you're going to be able to get that information through to them. Or I've written letters to them just so they have, it's like, for what it's worth, okay, I have healthcare proxy for this person and this is what I'm seeing.
Yeah.
And they usually,
caregivers don't always have the energy or the inclination or the chutzpah to do that, or they feel like they're doing something behind their family member's back.
Right.
And a lot of times the motivating factor is denial, fear of loss of independence, fear of having to be placed in a nursing home or whatever. So people lie just because they don't want to deal with the issues at hand. And a lot of times the family members don't as well.
Right. But if you have information that could help to inform
Absolutely.
and get them better care, it's a good idea. And you shouldn't think of it as lying. You should think of it as augmenting the healthcare professional's ability to care for your loved one.
Beautifully
I'm going to
said.
go back to our central theme of things that make you go, because one of the things that I found is we used to say that healthcare was an art and a science. And the way I explain that to people is the art was in the nuancing of getting a comprehensive HMP and knowing how to ask the right questions. And I tell people we need to become Columbo. One more thing. Wait a minute. What? Just one more question. That was his famous lines.
Rose, what's an HMP?
Oh, I'm sorry. Thank you. HMP, history and physical. Thank you. History and physical. And part of a comprehensive history questioning is around psychosocial, family histories. And part of that is, if I'm assessing a patient very comprehensive, I'm going to go to the family and say, is there anything else that you could share? Because again, that's not violating HIPAA, but that should be part of the clinician's job of, I got to investigate one more thing. But what I'm seeing again is what we talked about in the last podcast is, well, I'm just going to run a scattering of tests and I'm not going to do that investigation because, we're not getting down to the pinpointing of this is what I want to rule out based on what I'm seeing or hearing. And I'm hearing this from the patient, but I need to use that art, that intuition to go, I am not getting the whole picture here. So we've lost that art.
Well, we lost that art because reimbursement has changed so much that the reimbursement is so low. Doctors, in order to maintain their staff levels, the expectations that especially the Medicare and Medicaid requirements for all that kind of information, they have more staff now. So they're trying to see, you're only given a 10 to 15 minute window of time. And in that 10 to 15 minutes, they're supposed to assess, they're supposed to diagnose and then treat. And there's no time for conversation or even getting to know the patient. And that's when I tell my patients, look, if you're feeling stressed or hurried, or you think that you're not getting the amount of time you need with your practitioner, then you need to say, I need to set up another appointment to specifically talk about this. And I think, because I'm seeing that so much, they're in, they're out, and they're away before you have time to breathe. And I think for a lot of seniors, that's why I tell them, have your questions ahead of time, or the caregivers, have them prepared, written down. And if you need to, ask to set up an appointment in a relatively short period of time to address the questions that you don't get answered, because it's time is money to those practitioners. Sadly, that's the reality of our world.
Yeah.
Well, and again, going back to HC Aware, that's a lot of what I'm trying to teach people is, how are you to be prepared and champion your own healthcare so that you partner with that physician? Because again, there are still some lovely, great doctors out there, but like you said, is they're being dictated to it. You got 10 minutes and 10 minutes only.
Yeah.
Which for some patients, that might be fine. For other patients, that is not going to be okay. So that's a lot of what I do with HC Aware is, how do we teach the public to do this, to partner with clinicians to champion their own care, be in the driver's seat versus reactionary.
We have a lot, we put the healthcare profession, the healthcare delivery system really puts a lot of pressure on each individual to be totally responsible for everything about their healthcare. The pharmacist, you used to be able to go into the local pharmacy, know your pharmacist, and say, hey, I'm taking this drug, and they go, wait a minute, maybe this isn't the right time for this. Your pharmacist knew you, they knew your medications, and you were able to have a conversation. Now you're forced to do mail order. So, and I know from my own personal experiences, a medication is discontinued, and they still want to send it to me. And I go, no, no, no. Or they'll
Right.
have sent it to me already and I don't need it. Or I don't. And so people don't, doctors, patients, and this is another thing I do. You have to sit with your doctor and let them know your updates. What's going on? Have you seen a specialist? What did that specialist say? Is that specialist communicating with your doctor? Have you sat down with your doctor and had a yearly or twice a year conversation on, these are my medications. Which ones can I get off? Which ones do I need? Because we're always adding medications, but we're not always taking away.
I have a nightmare story for you on that. I was helping champion with an elderly woman. She
Rose,
went
I'm sorry. I could go on talking with you guys like forever, but we're running out of time here. So
there you go. Cut us off.
There you go.
Yeah. Cut us
but
off.
I would love to have let's continue the conversation because this is great. And before we sign off for today, Rose, can you tell people who are listening, where can they get in touch with you? What's the best place for them to find you?
Oh, thank you. Yes, it's Delphine HC Innovations. So my website is DELPHINEHC.com. And that's the best way to email me, reach out to me, read case examples. I'm trying to get a national program called I Wish I Had Known, because that's what everybody says after they find out this information. They're like, I wish I had known.
Mm-hmm. And Diane, please tell our viewers how they can get a hold of you.
Caregiverrelief.com.
Awesome. And also, if you're a good kid and you're a member of the Good Kids Club, Diane is also an active member, so you can also find her there. So I really want to thank my friends Rose Rohloff and Diane Carbo for joining me here today. I hope that this incredible wealth of information was valuable to you, and I wish everyone a wonderful weekend. Thanks so much.
You're fantastic, Tracy. Thank you for hosting.
My pleasure. Thanks. And let's get together again soon. We're going to have to schedule another one because this is just too much fun.
Agreed.
All right. Take care.